I request my first co-instructor, Dr. Rajan Anand, to talk on tackling cataract in a previously operated eye. This eye who has undergone open glove injury and has been operated earlier.
Good afternoon, everyone. Thank you, Dr. Subhash, for providing this opportunity. We had this instruction course in the last virtual conference also, and the viewers' response was good, and that is why Dr. Subhash has been given a different chance. With some modifications, some additions, we are presenting it again. My topic is cataract surgery after an open globe injury. And this is a very common situation that we come across. There are no financial disclosures to be made. 65 to 80% cases of traumatic cataracts are due to open globe injury, and it is commonest among children and young adults. The globe injury mostly are in the areas of cornea, limbus or sclera. Associated anterior segment injuries or posterior segment injuries may be present. One important thing is when to take up the cataract surgery. Either primary, that is while you are doing the repair, or do the repair and take up cataract surgery later. Later is the better, is a general concept, because the surgery is easier, the cornea will be clearer, tissue will be less reactive, IOL calculations will be more accurate, better chance of in the bag placement. Although there is a contrarian view, there is a study in Tehran in 30 cases, and they found no difference in the BCVA in primary and secondary procedures. Preoperative workup is important because there is not just ordinary cataract. Documentation, there may be medical legal issues. The visual prognosis should be explained and written. Extent of open globe injury prior to management of the lens injuries, the presence of lens dislocation, capsular tear. So whatever pathology has occurred, whatever damages have occurred, you should be aware of it before taking up the case. An X-ray, CT or USG if you suspect an intraocular foreign body. Determining the type, whether it's cortical, nuclear or a capsular, and the extent, a focal or a total cataract, has to be seen first. Intraocular inflammation, there might be iritis, posterior segment trauma, lens-induced glaucoma or uveitis. Take care of these first. And a high IOP is very common. PAS, pupillary block, angle recession, these things should be included in the preoperative workup. You should be sure of what you are going to deal with. Biometry and IOL selection again is a bit challenging. If this eye is so bad damaged, the cornea is so bad that you can't get a K reading, then we have to depend on the contralateral eye. An acrylic single piece or a multi-piece foldable in the bag would be preferred, but you may have to implant it in the sulcus. When sulcus fixation is desired, obviously a 3-piece lens or a single piece PMMA. AC lens may or may not in an elderly patient with good iris support, no evidence of glaucoma, and AC is free of vitreous, then you may think of an AC lens, or an SFIOL if you are competent enough and the tissue allows it. No AC IOLs in children, please. The first thing you'll do is to manage the capsule, and it may be torn. If it is intact, you can do a CCC, avoiding zonular stress. If it is ruptured, cut away the tags and fashion an opening as close to a CCC that you can make. Remember, old capsular openings will have fibrosed margins. Remove or break the synechia if they are present. If there is a 30 to 90 degree of zonal dialysis, use a CTR. If more, there are other options like the capsule fixation rings, the Sioni rings, segments, and glued hooks designed by Dr. Susan Jacob. If there is an extensive subluxation, you might have to do an ICC with a secondary IOL. If there is vitreous in AC, first do an appropriate vitrectomy. Now, these are some traumatic cataract cases. You can see that the capsule is cut and fibrosed in this picture. This is almost a total subluxation. You can just see the top of the lens here. I doubt if you can repose it, and maybe you'll have to do an ICC in this case. After we have managed the capsule, now the nucleus management. Generally, these are young patients, and so the lens matter is soft and can be aspirated by a bimanual or a coaxial IA or Simcoe. If formed nucleus is present in adults, do a slow phaco procedure. Any difficult situation in cataract surgery, you'll hear that word, do a slow phaco. So what is a slow phaco? You don't give more time to it, you reduce your parameters. If corneal opacity is hampering the view or the nucleus is hard, you may even consider SICS. And if corneal scarring is gross, you may think of a keratoplasty and a cataract surgery together if you have a corneal surgeon or if you do a keratoplasty yourself. प्रीव्यू में था मिनिमाइज कीजिए
इनेबल तो कर दिया मैंने
क्या हुआ
इनेबल तो कर दिया फुल थ्रेड
You can see a capsular opening and there is a synechiae. This is a coaxial IA being used, and this is Dr. Subhash's case. He's just aspirating it carefully. There might be vitreous anywhere. This injury is old, and so you can see that the capsular margin is quite fibrosed, and he is able to implant a single piece acrylic in the bag. Now he is using a vitrector. That is the point where he suspects that there is some vitreous. So the lens is placed nicely, and this young gentleman is going to get a decent vision. This injury is a bit bad than the previous one. This synechiae, there might be zonal dialysis that side. He is trying to fashion a rhexis. The capsule is fibrous, thick, couldn't do it with the needle, opened it with the MVR and then using a rhexis. Careful towards the site of injury. Again with the coaxial IA, aspirating the cortex. And a multi-piece lens in this case. Try not to fiddle more in the area where you suspect the injury is more, because you don't know what's underneath. And so even this case has been managed nicely. This was a case repaired, corneal injury repaired about 3 months back. This part, the sutures are still there. So I give 2 nicks and try to fashion a rhexis. But towards the injured capsule, it's not tearing off, so I have to use a varnish to cut it off. And this is with the phaco probe, but in the IA mode. So you don't have to use phaco power. Soft cataracts usually get aspirated. A bit of nudging with the dialer. and that small piece left, now going down is risky, so I remove that with the by manual. And so this case has a decent rhexis now, but I still implant a 3-piece lens. There is a young patient. And this was third post-op day of the same case. Is as good as it can be. Now this is a 8-9-year-old girl. You can see the tear here. It's just a 3-day-old injury. It's still gaping, and there's a fluffy cortex underneath it. So in this case, I had planned to do the repair and the cataract removal together. Unfortunately, the patient did not turn up for surgery, but I think she must have got it done somewhere else. In such a situation, I would have done a combined repair and cataract, because the fluffy cortex can't wait for long, and this cornea has to be repaired first. The prognostic factors, you've done the surgery, okay. The prognostic factors depend on what was the initial visual acuity. An open globe have better post-op vision than a closed globe injury, because in a closed globe injury, the retina might have been compromised. Location of the wound, and there's an ocular trauma score, which gives a good predictability of the post-op vision depending on these factors. Follow-up has to be long, because these are young patients, and it's not a routine cataract. You cannot predict the behavior. There's a risk of infection, glaucoma, developing amblyopia, PCO, posterior segment complications, and of course medical legal, which doesn't leave us. So the summary is, there can be a variety of presentation. Decision making is important as your skill. Management of traumatic cataract is challenging. Outcome depends on collateral injuries, but usual vision can be restored. Thank you, and I acknowledge Dr. Subhash Prasad and Dr. Nazneen for some material they have provided to me. Thank you very much.
Thank you, Dr. Rajan Anand. Rajan Anand is actually a very senior ophthalmologist and is very good orator and has been the chairman scientific committee of Bihar Ophthalmological Society. So any question from audience regarding this, managing these cases of trauma who have undergone repair, primary repair, or going to have for secondary repair? One thing is very important, that no two cases are similar. In any case of trauma, the two cases are different. They have to be approached differently. And regarding post-op management, all of these patients can develop some type of complication like glaucoma, posterior synechia, so they have to be followed very regularly. And apart from that, amblyopia therapy is must in these patients, because all are children. So, anything else?
Dr. Subhash, when there are no questions, there are just two situations. Either I couldn't deliver what I wanted to say, or it is so common that everyone knows about it.
My question is, in case of the perforation of the cornea with the anterior capsule damage, you go for the corneal repair and for cataract operation. What is the mode of power, IOL power calculation? Is it better to other eye or standard power?
Yes, because in this eye the cornea is scarred. You might not get a good keratometry. You can take the K reading of the other eye. If you can get an axial length of this eye, fine, or else you have to depend on the axial length of the other eye also.
Thank you.
What are some of the primary investigations you must do before taking up these injury cases for surgery?
Apart from your routine cataract workup, X-ray or a CT.
In connection with the trauma?
In connection with the trauma, an X-ray or a CT to see for a foreign body, and maybe an OCT to see if there's vitreous hemorrhage or not, or posterior segment complications. I mean, associated injuries could be in the posterior segment or in the orbit.
One of the most important thing in these kind of cases is the medico-legal issue. They come with the expectation कि चोट लग गया, रोशनी चला गया, डॉक्टर साहब ऑपरेशन कर देंगे, कल मेरा रोशनी आ जाएगा, which doesn't really happen. So you have to have that consent form very, very carefully filled so that you don't fall into trouble.
I would suggest if you suspect that this patient is going to create problems, have a video recording of your counseling.
So what is the protocol of end-of management you do in cases of trauma patients?
Trauma end of after the surgery or?
No, sir. Whenever a trauma happens, either the soil particles can also predispose to end-off in the patient. So what are the precautions you take before that?
Precautions or management of end of? What are you asking? Precautions. Precaution is if you are dealing the injury first. I mean, if the patient has come to you with the injury, and this is a situation when there was an injury, it has been repaired, and he has come for a cataract surgery. So if you are dealing with an injury as such, then obviously the antisepsis, cleaning the wound before suturing, if you can give an intracameral, follow it up for the first 3 days, that is the time when end-off will occur. And if it occurs, then manage the end-off with intravitreal injections, 1 or 2, and then vitrectomy. The treatment of endophthalmitis will be the same.
All open glove injury must be given antibiotic, systemic antibiotic also. And like in our cataract surgery nowadays, we used moxifloxacin, so we can use intracamerally moxifloxacin in all cases. And we have to be very observant, vigilant for initial few days. That is most important thing.
I
So-
think you can be aggressive. If you said soil, it could be anything, and the things can get worse very fast. So you can close the globe and take a VR opinion and go ahead and straight do a vitrectomy at that point of time if that is warranted.
And a daily follow-up if you're dealing with the injury.
Thank you.